Surgical anatomy of carotid endarterectomy. Welcome to this episode of the Everything Surgery podcast, where we take a deep dive into the surgical anatomy and operative nuances of carotid endarterectomy. Today, we will explore the essential anatomical knowledge, critical structures, and surgical steps required for this intricate procedure. Introduction to the procedure. Carotid endarterectomy is a surgical intervention performed to remove atherosclerotic plaque from the bifurcation of the common carotid artery and the proximal segment of the internal carotid artery, while maintaining the integrity of the external carotid artery. A precise understanding of the vascular anatomy, including possible anatomical variations, is crucial for avoiding operative complications and ensuring a successful outcome. Key anatomical landmarks and incisions. The initial incision is typically made along the anterior border of the sternocleidomastoid muscle, centered over the carotid bifurcation, which generally lies at the superior border of the thyroid cartilage, between the third and fourth cervical vertebrae. In cases of high bifurcation, the incision may be placed as high as the first or second cervical vertebra. Dissection proceeds through the platysma muscle, followed by opening the carotid sheath. The vagus nerve, the 10th cranial nerve, is almost always positioned posterolaterally, between the internal carotid artery and the internal jugular vein, but may be found anteriorly in a minority of cases. The hypoglossal nerve, the 12th cranial nerve, crosses superficial to the internal and external carotid arteries and is commonly mobilized by dividing the ansa cervicalis and branches of the occipital artery. The common facial vein serves as a key landmark. Its ligation and division provide excellent exposure of the carotid bifurcation, facilitating precise surgical access. The carotid triangle and critical structures. The operative dissection is primarily conducted within the carotid triangle. From superficial to deep, the sternocleidomastoid muscle is retracted laterally, followed by the internal jugular vein, which also lies lateral to the carotid arteries and is retracted along with the muscle. The carotid sheath encloses the common carotid artery, internal jugular vein, and vagus nerve. The common carotid artery is the primary vessel exposed during the procedure. The carotid body is located at the bifurcation of this artery. The bifurcation itself is the target site for plaque removal and can present anatomical variations such as a high or low bifurcation or medial kinking. The internal carotid artery, which is the vessel most affected by disease, is usually posterolateral to the external carotid artery and does not have extracranial branches. It is crucial to identify the distal, healthy segment of the internal carotid artery for safe clamping. The external carotid artery is typically anteromedial to the internal carotid artery. Its first major branch, the superior thyroid artery, is often controlled during the procedure. Preservation of the external carotid artery is vital for maintaining collateral circulation and as an anatomical landmark. The ansa cervicalis, a loop of nerve fibers from the first to third cervical nerves, lies on the anterior surface of the carotid sheath and is often divided to allow mobilization of the hypoglossal nerve. Critical cranial nerves. At risk. Injury to cranial nerves is a significant source of postoperative complications. The vagus nerve runs within the carotid sheath, usually posteriorly and between the internal jugular vein and the carotid arteries. It must be identified and protected to avoid vocal cord paralysis caused by injury to its recurrent laryngeal branch, as well as potential cardiac effects. The recurrent laryngeal nerve, a branch of the vagus nerve, loops around the subclavian artery on the right side and ascends in the tracheoesophageal groove close to the operative field. On the left side, it loops around the aortic arch and is less frequently encountered. Occasionally, a non-recurrent laryngeal nerve is present, most often on the right, and is at exceptionally high risk if not recognized during surgery. The hypoglossal nerve crosses superficial to the internal and external carotid arteries, often just above the bifurcation. It is mobilized by dividing its tethering vessels, including the occipital artery and the ansa cervicalis. Injury to this nerve can result in weakness and deviation of the tongue on the same side. The glossopharyngeal nerve lies deep and superior, near the pharynx, and is at risk during high dissections. Damage to this nerve may affect swallowing and the gag reflex. The marginal mandibular branch of the facial nerve, which runs superficial to the submandibular gland, is susceptible to injury from high retraction or incisions, leading to drooping of the lip on the affected side. The greater auricular nerve, running superficially on the sternocleidomastoid muscle, may be injured, causing numbness of the earlobe. Anatomical variations and high-risk situations. Several anatomical variations and situations increase the complexity and risk of the procedure. A high bifurcation or elongated internal carotid artery requires more extensive dissection and increases the risk to the glossopharyngeal and hypoglossal nerves. A low bifurcation may extend into the mediastinum, necessitating supraclavicular exposure. Carotid kinking or coiling alters the geometry of dissection and clamping, while plaque extending to or above the angle of the mandible presents a significant challenge. Prior neck surgery or radiation therapy can distort tissue planes and cause scarring, further complicating the operation. Surgical sequence. An anatomical perspective, the operation proceeds through several key steps. First, the common carotid artery, external carotid artery, and internal carotid artery are exposed and controlled distal to the plaque. Next, the surgeon identifies and protects the vagus and hypoglossal nerves. The vessels are then clamped in the following order: distal internal carotid artery, proximal common carotid artery, and the branches of the external carotid artery. A longitudinal incision is made from the distal common carotid artery into the internal carotid artery, passing beyond the endpoint of the plaque. The plaque core is removed, ensuring a smooth, feathered endpoint within the internal carotid artery, and the orifice of the external carotid artery is averted and cleaned. Closure is accomplished either by primary repair or using a patch angioplasty, which may involve autologous vein or a synthetic material. Summary: the safety and success of carotid endarterectomy depend on meticulous, layer-by-layer anatomical dissection and a constant awareness of critical areas where cranial nerves are at risk. Particular attention must be paid to the vagus, hypoglossal, and glossopharyngeal nerves. Anticipating normal anatomy, recognizing common variations, and understanding the pathological changes caused by atherosclerotic plaque are essential for achieving optimal surgical outcomes. Thank you for joining us on this journey through the surgical anatomy of carotid endarterectomy. If you found this episode informative, please like, share, and subscribe to the Everything Surgery podcast. Stay tuned as we continue to dissect the extraordinary.